What is going on here? Okay, there we go. All right. So impairment is loss or abnormality of either psychological, physiological, or anatomic structure or function. Oh, did you all mute yourselves? That's not going to work.
I'm unmuted now.
You're okay. Do you want to answer it?
No.
Okay, that's fine.
I'll pass that question.
That's totally
phone
fine.
friend.
Anybody have an answer for receptive language?
If you're too shy to speak, there's a chat section.
That's true. There is.
Able to understand.
Yeah, right, exactly. So that's going to be understanding. And then I want you to also know expressive language, which is communicating, just communicating with others, but you getting your words out, communicating your thoughts and feelings with others. Yeah, thank you, Abby. All right, so which is more variable? Is it the time of development, like how long it takes for things to develop in children, or is it the order of development? One of them is pretty stable and one of them is pretty variable. If you're looking for the chat thing, you can scroll up to the top of your screen and it's under more, or depending on your view, it might just say chat at the bottom of your screen. It's... Any guesses? No? Okay.
Time.
Did you say time? I think
I'm just guessing.
You're just guessing? Okay. I'm sorry I have to do this. Yeah, time is definitely more variable. You're absolutely right. Good job. Yeah, time's more variable. I mean, we know that we have that chart that shows like 50% to 90%. This is when children are expected to get things. The order of development is pretty stable. And so when the order gets, disordered, then that's more of a red flag that something might be going wrong. So, yeah, time. Good. All right. You'll also need to know form, use, and content. Form, of course, is syntax, morphology, and phonology. These are, right, the speech sounds, and, phonology and morphology are speech sounds, and then tacking on other units of meaning to words. Use is going to be pragmatics. So those are a lot of the social cues. And then content is semantics, and that's like the meaning of words and when to use certain words. Sorry, I've got this weird hey, oh, that's not good. I'll shoot it right in my fan light. Okay, so then semantics is like the meaning of words and when to use, which word. All right, so typical development. In infants, what do we expect to see around... Oh, sorry. Okay, there we go. What do you expect to see around 4 months? This is kind of a huge...
Like babbling?
Yeah, good. It's, it's vocal play is what I've got on here, but yeah, like babbling, the child's going to be using their voice. It's not just that reflexive, not those reflexive sounds like the grunting and burping and stuff like that, but it's moved into actual vocal play. So just using the effectors and the vocal folds to create a bunch of different sounds. By 10 to 15 months, that moves to jargon. And that remember is that, dang it, that that is the video that we watched with the maybe 3 times I think we've seen it, which is okay because it's a really great video, of the baby and the dad watching TV, and the baby is not saying anything that you can actually understand, but it's using jargon to like mimic an actual conversation. So that's somewhere between 10 and 15 months. You'd also see that a lack of gestures and a lack of that kind of imitation may be a hallmark of impairment. I mean, it's at least a red flag. It raises a red flag to say that there could be something strange going on, because there's a lot of mimicry of gestures, mimicry of sounds. When you say babbling noises to a baby, then they'll start saying the same babbling noises back at you. So that's the imitation and mimicry. In toddlers, what happens around 18 months? Who knows the answer to that one? Okay. It is word explosion or word spurt. I think word explosion sounds cooler, but you could go with word spurt too. So that's around 18 months. And then towards the end of the toddler ages, you're going to end up, well, during the toddler ages, you'll see like the emergence of the first syntax with 2-word sentences. So they'll be putting 2 words together to form pseudo sentences. And then in preschool age, I guess I'm going to have to move this thing again. There we go. For preschool age kids, you expect that their language is mostly intelligible. It's 75% intelligible at 3 years and 100% intelligible by 4. So up to 4, it might not be 100% intelligible, but somewhere within, around 4 years, you should have 100% intelligibility. And again, that's for non-familiar listeners. And then you'll also see things like jokes and different word classes emerge. I mean, they're not great jokes. Like, kids don't have a great sense of humor, but they're jokes. All right, and so then I want to move on to talk about risk factors. When babies are just born, some of the things that we know that could be risk factors are being deaf or hard of hearing. Does anybody remember why that might be an issue? That's a pretty important thing. No? Not even in the chat? It is because... trying to drag it out to see if anybody else answers. So if they're not getting the right auditory information, then they don't really know what they need to mimic, right? So if they have a hearing impairment that knocks out a lot of their high frequency hearing, they're only going to hear kind of like a low frequency mumbling, and that's going to create some sort of speech impairment. If they're completely deaf, they won't be able to hear any of the speech sounds. So that's definitely going to slow them down for a lot of that mimicry. Gesture mimicry would still be there, but not the vocal mimicry. And even hearing their own vocal play is a huge part of being able to understand what we need to do muscularly to create the correct speech sounds. Because we're kind of building these correlations between, like, well, if I tighten this and it feels this way in my throat, that's a higher pitch. Or if I do this, that makes it louder. So not being able to hear those things removes the correlation between them, and then we're not able to learn them. So that's why being deaf and hard of hearing is a risk factor. We'll hear later on in the class, not for this. That's okay. We'll hear later on in the class, but not for this exam, that we try to screen children as early as possible to see if there's any deafness or hard of hearing. And that way you can get them the services they need to, if their parents agree, so that they can, not have those issues later on in speaking. Down syndrome and cleft palate are also potential risk factors. Down syndrome because it's correlated with lower IQ, and cleft palate because, as you know, you're not able to make the speech sounds. You're not able to keep the high pressure sounds on to make the speech sounds, so that doesn't give you a lot of practice with those. So you might even have problems later on. In addition to that, you can end up with the submucosal cleft palate that is hard to be repaired because it's muscles that are actually missing. And so then they might not just be able to produce the speech sounds that are necessary even after surgery. Okay. In preschool age children, we're looking at one risk factor or sign of impairment is that they don't have a lot of conversational range. They might be kind of stuck to one topic. If it's something that they've practiced a little bit, they know that there's more content there, so they'll stick to that. There's also not a lot of grammatical range, so they'll keep sentences very easy, right? So they'll stick to our typical subject, verb, object order and not branch out and do more interesting, things the way that we talk. They'll stay in a simple, almost telegraphic grammatical range. And then by school age, throughout the school age, you also notice that children with speech impairment have a hard time with narrative structure. So they're not able to form a good story, with a beginning and a middle and an end. Things get kind of lost. Figurative language is a problem, like metaphors. Idiomatic phrases are also difficult. So, so anything that's not really concrete is kind of difficult. And you'll also see that simple sentence structure pervades into this area as well, and also into adults if it goes untreated. But you would expect to see the simple sentence structure there too. Okay. What? Oh, I'm reading that the wrong way. I just wrote this, and I'm like, use impairments. What does that mean? It's use impairments, not use. We'll see a lack of initiation at all ages if there's an impairment. So if it's a school age child, they're not going to start conversations. Preschool age children won't start conversations either. Even as toddlers, there's not that pointing, and babies won't initiate the shared attention either. So that's one red flag. We talked about most of the rest of this, difficulty with storytelling. Social language in teenage years can also be a problem too. So that kind of moves into the pragmatics area, but the pragmatics can be limited with older school-age children. They won't really understand social conventions in the way that we talk. We also talked about this too. I don't know why I put this on here twice, but limited vocabulary and trouble with homophones. I guess we didn't talk about trouble with homophones, but there and there, Amy's example of how many different types of bear are there spelled the same way. So this will show up. So people who don't, or children who don't really grasp the differences between the multiple meanings of bear. Does anybody remember what DLD stands for?
Developmental language disorder.
Yes. Good job. And so DLD, which occasionally you'll also see as SLI, and I think one other thing, right, Amy? Something else as well? Or is it just DLD and SLI? I think your microphone is off. No.
I think you have to enable the microphone somehow.
Huh.
Key.
Well, all right. Sorry about that.
Just chat it up.
Yeah, we'll chat it. Yeah, chat it up. That's good.
Chat, very good idea.
Okay. And the accepted one, the one that we're trying to push more towards is DLD. Is that? Okay. Okay. She's shaking her head. Okay. So, good. So DLD, and this is going to be, like you said, it's developmental language disorder, and it is a condition where the language disorder exists as the main problem. That's the main problem. It's not a secondary problem to anything else. For instance, Down syndrome, the language disorder that could result from that is a secondary disorder to Down syndrome. But in this case, the language disorder is the primary problem. And it could show up with other diseases. So it doesn't have to just show up on its own. But again, it's the primary disorder. And what you see with it is an impaired vocabulary, impaired structure, impaired grammar, and then also you can see impaired pragmatics as well, so poor social cues. Something that is not exactly the opposite, but it's definitely kind of a sort of a flip of the coin. It's just different, I guess, is specific learning disorder. And that's where all academic skills are impaired. So it can present with DLD, but it doesn't have to. They can exist apart from each other. But specific learning disorder is all academic skills. You would expect language, math, or writing, math, all these other things. Academic skills are the primary problem. And then DLD is just language skills specifically. Does anybody remember what the language progression for Down syndrome is? Like, how is it disordered? Or is it disordered at all?
In my notes, I have that the language is delayed more than deviant, but I don't recall what deviant meant.
Well, so deviant is, like we talked, the timing is really variable for a lot of kids, and that you're exactly right, by the way. Great answer. So timing is really variable, and then the actual order that it develops is pretty stable. you would expect that for a lot of these language impairments, things are out of order, things don't show up when they need to. And so what that means for Down syndrome, kids with Down syndrome, is that it comes in the right order. Like they're progressing in the same way that neurotypical kids are. It's just that they're more delayed than typical kids. Like their progression of catching on to things is slower than everybody else, but it does progress in the typical trajectory. So they do eventually, end up having a lot of typical language abilities, mostly, and so it's just that it's slowed, not that it's different or disordered in any way, really. Great answer. And my slides aren't advancing. There we go. Okay, so I have one thing to say about assessments, which is the best assessments are standardized. The norms and the standardized assessments are going to have norms and criteria. Sorry, my chair is very noisy. That will help gauge performance. So it removes subjectivity from the assessment if you have norms and criteria. You can say that the child you're testing is in the 50th percentile for their age range, and that's a problem. Or you can say they're in the 90th percentile for their age range, and you know that they're doing just fine. So that's the kind of assessment that you want, is one that is standardized and that has published norms and criteria. Okay, so now neurogenic speech disorders. There's a ton of questions on here, but they should be pretty easy. What is TBI?
Traumatic brain injury.
Yes, 2 or 3 of you who answered at the same time. It is traumatic brain injury. That's exactly right. You can have that. It shows up in a variety of ways. TBI can be a penetrating injury or not, but either way, it's sudden and acute damage to the brain. Let's see, do I have... All right, yeah, that'll come later. Okay, so what are some of the common... What is one common short-term effect of TBI? When I say short-term, I mean like...
Loss of consciousness.
Yeah, good. Loss of consciousness, exactly. Good job. So loss of consciousness. In terms of aphasias, we do see that people who have TBI will present with possibly aphasias. Like as soon as they wake up or a couple days after the event, they might show types of aphasias, but you don't want to call it right away that they have some sort of aphasia, because that can go away. There's a lot of strange things that happen. It's not just aphasia. It's confusion. It's not remembering things, amnesia, all sorts of things like that can show up right after traumatic brain injury. But then as the brain has a chance to heal a little bit, or at least, reduce the swelling from the damage and kind of get back to normal, those things may completely go away. It's only a problem when they don't, and then after maybe, say, a week or so, then we would say, like, oh, they've got aphasia. And yes, dizziness, exactly, good. What are common long-term effects?
Mood swings.
Mood swings is definitely a possibility. But the weird thing about TBI and memory, yeah, exactly. The weird thing about TBI is it's really different for everybody. Like some people have mood swings, but that depends on the area that ended up being damaged. Some people have memory loss. Again, that's the area that ends up getting damaged. So there are some few common short-term effects, but then the long-term effects are just kind of all over the place. Yeah, concentration issues. That's actually more common than, that could be one of the most common of them. But even so, there's a lot of cases where that doesn't necessarily show up. So long-term effects are very strange. But yeah, concentration issues is a great answer. Very good. They're all good. Oh shoot, I already gave that answer away. Men are more at risk for TBI than women. That's probably more of a social thing than anything else. They tend to, at least in Western cultures, be more risky and do dumb things. So that makes sense. What are other causes of neurogenic speech disorders? Or what are causes of? I mean, what are some causes of TBI or other neurogenic speech disorders? Yes, stroke, exactly. Good. Anything else? Stroke is definitely the big one that I want you to know. Car accidents, perfect. Yeah, absolutely. Degenerative diseases, good. Yeah, absolutely. And then I've got also 2 on here that are, yeah, sports real, yes, good. Concussions, exactly. Yeah, you guys are doing really good at this. So I've also got tumor and parasites that I haven't seen yet. So those are other causes of neurogenic speech disorders. Parasites usually can be removed, but they kind of pose the same problems as tumors, just, growing somewhere and pressing on areas of the brain. And stroke is really the huge one there. Yes, it is going to be posted after. Stroke is the huge one. It's only because it's so common. Much more common than parasites. Although car accidents are very common too, so hard to say. All right, so do concussion injuries mimic typical neurodegenerative diseases? This is just one simple answer. Like, can you say, oh, you know what? Let me make this a different question for you. So they might mimic it outside. What about internally when you look at brain, the way that it affects the brain? Yeah, no, exactly. Good. Yeah, not at all. So the actual behavioral issues that can come from these might look like typical neurodegenerative diseases. You can end up with, again, a lot of confusion, forgetting things, and it can look like dementia, which again has another slew of long-term effects with dementia. But when we actually look at what's going on in the brain, the areas of the brain that are affected at different times, concussion injuries they show up completely differently. So we can definitely say that it's not that these people who are showing the problem with the chronic encephalopathy, man, concussion-related encephalopathy, just had dementia earlier. It's actually something that is caused by repeated concussions. And some of this could be due to this coup-counter-coup injury. That's a really ridiculous term. All it means is like a blow and a counter blow, sort of. So your head moves forward, the brain hits the front of the skull, and then it rebounds and it hits the back of the skull. Or it hits the side and then it hits the other side. Whatever. But it's just because it's kind of like it's able to move inside the skull. So in a large, accident or hit that causes a concussion, the brain would move and then come back. And so you can get 2 strikes, but sometimes 3, depending on how hard the hit is. And then you also end up with shearing effects as well, which can actually break the neural connections because of the twisting motion that can happen with some of these concussions. So if the head is twisted, the brain inside can move as well, and then you can end up with it kind of pressing up against the skull and shearing some of the actual neurons. And that's not what's going on with dementia and Alzheimer's. So even though outwardly they might present like that, we can tell by the progression of the disease that it's not the same thing. Okay, what does ischemic mean, or what does hemorrhagic mean? What's the difference between the two?
Hemorrhagic is when it's like bleeding.
Yes, exactly. Hemorrhagic is bleeding. Ischemic is an obstruction. So,
A blockage, right?
blockage, exactly. Yep. So ischemic is a blockage. A hemorrhage is a rupture. Oh no, I gave it away. Maybe you didn't see it. Does aphasia only impact expressive speech? No, exactly. Good job. It does not. So it can impact expressive, it can impact receptive, it can impact only mimicry. There's others that are very strange that it can impact. So it's expressive language, it's receptive language, it's mimicking. It's all these things. It kind of depends on the type of aphasia. Also, I guess I did give it away with having Broca's and Wernicke's aphasia right below that question. Whatever. You knew it anyway. So Broca's aphasia, in the very textbook cases, they might have difficulty getting words out. But it's clear that they know the word. So let's say there's a video that I can't find. I think it's because it's behind a HIPAA wall. But this guy is trying to say ladder. And he's pointing to it and he's motioning like somebody goes up a ladder. And all he said, he can get out zoom, like he makes this sound for going up the ladder. But he can't say the word ladder. So he knows it. He knows it's there. He knows he can't say it. So he's aware of the deficit. But it won't come out. He can't pull the word out, to make him say it. It's stuck up here somewhere in the brain. If you said ladder, he would know that was the word he's looking for, but it just won't leave it. It's almost like a permanent tip of the tongue kind of thing. Wernicke's aphasia is very different from that. They have difficulty understanding what people are saying to them. There's this word salad that comes out. They have no real comprehension of their disorder. The green shirt guy that was on the cruise is probably the best video of textbook Wernicke's aphasia that I can think of. He's, if you remember, just saying just ridiculous stuff. She asked him, what were we doing out on the iPad? And he's like, well, they're all out there diving in them and hand in hand and whatever. And he has no comprehension that he's not making any sense. So it's very different from Broca's aphasia, where they're acutely aware that they cannot get the word out that they're trying to say. Wernicke's aphasia, no awareness of what the problem could be. The goal of aphasia treatments, I don't remember if, I don't think this was in Hala's PowerPoint. I think it was in mine, but I'm not sure. But either way, it's one of the most important things to take away from the aphasia lecture. I mean, it's really interesting, but the most important thing to take away for people who are going to be, therapists, is what are you working towards with aphasia treatments? You're not going to get them back to where they were. That's just, a sad fact. They're not going to have the same language life that they used to. But you want to enhance the quality of their life however you can. And even if it's just one person's name, so like their spouse or a child or a dog, you know, something like that, if it's just one word or one name that they can say, that is enhancing their quality of life, so that's good. If you just get them to say one thing that they want to, you've done your job. I mean, you should try to get them to say more. I'm not saying only do one and quit. But if it's a really difficult case and you can only get the one, like that's still, you've done your job. So that's the goal. The goal is definitely not to get them back to where they were. Unless for some reason you can, then of course do that. But what are some common language deficits after TBI? We kind of talked about these, so I'll just go to them. So finding words, we know that. Broca's aphasia and some other aphasias, you have difficulty finding words. But even just putting them together, like even if you can find your words, it's a like kind of a labored process of putting the words together and putting the sentences together. You can end up with pragmatic problems, like not understanding metaphors the way that you used to. And then also, it seems to impact your working memory quite a lot. And this is one of, if we're going to say that there is a common thing with TBI, which of course it's hard to say because it presents so differently, but working memory deficits are up there, and confusion, that are things that are difficulty concentrating. Those are all things that would be in contention for common problems. So keeping track of where you are in a long narrative would be a problem. And transitioning between talking about one thing or to one person and going to another one, that can take a long time to move from one to the other. Whereas we can do it, you know, go back and forth pretty rapidly. Okay. Okay, I need to move over to a different slideshow. That's the same one. There we go.
Can I ask a quick question?
Yeah, absolutely.
Is it with Broca's aphasia when you're aware of the deficit, or is that Wernicke's?
That's Broca's. In Broca's aphasia, you're aware of the deficit. Yeah. Good question.
Okay, thank you.
Yeah. Okay, so speech science, there's just a few things I want to talk about here. Okay, so the source filter model. Breathing is the power source. You have to be able to take in breath to be able to push it out through the vocal folds to create a... The vocal folds are the sound source. They're going to create like a buzzing sound. And then the pharynx and the mouth, words. So this is something you should definitely know. I think this might have too, but you're not going to get away from it. Okay. Okay. I think I have to move this. I'm not actually sure. You're going to have these two blue triangles. These are your vocal folds between the two. So if your vocal folds are adducted, which means they're pressed together, the air is going to come up between them. Tension, right? So I have, if you pull the two strings together and they're held there, the air would blow them apart. And this is actually kind of a dumb... A rubber band would have worked a lot better, but I don't sit around with rubber band. So this is how sound is actually produced in puffs of air, is that it's going to release. So it's not just like one sound that creates the actual sound. And what it actually does is it creates pressure waves. Right? Air comes out and it creates a high pressure area, and then the vocal folds close, and then there's a low, which is interpreted by the ears as a sound wave. Okay. And going. That's all it is. And what it means is that your fundamental frequency is the first basic frequency, so the actual puffs of air that are coming out, the timing between those, that's the fundamental frequency. Harmonics as well, and harmonic overtones. And those harmonics are going to exist at the spacing of the harmonic. If you had a 300 hertz fundamental frequency, you'd have harmonics at 300, 600, 9. So you just multiply the fundamental by 1, 2, 3, 4, 5, 6, 7, 8, 9, and those are your harmonics. So again, that's produced by the vocal folds. But resonators are going to change the shape of that and change which is the strongest. So this top thing here at the very, the blue bars that just keep going forever, that is what's coming out of, those are your pharynx in your mouth and your nasal cavity, and they're going to have different, resonate well with those, and they'll enhance frequencies that do resonate well with those. Bottom, where you have those same blue bars, but then some of them are more powerful than the others. And those powerful bars are how we tell the difference between an E and an and an oo. That's down here. So this thing I think is between, whoops, sorry. This is the difference between an and an E. Assume the, but probably not exact. But you can see that the formats are in totally different. So again, the fundamental frequency by all of your resonators and articulators to create these different formats of different consonants and different vowels and all of speech. I pull up the last thing I wanted to go through. Okay, and this is the one that has way too much about the basal ganglia, which I'm not going to ask you a ton of questions about. Easy question. Do we have perfectly fluent speech, all of us? No. No. Okay, cool. I'm seeing, yeah, we don't have perfectly fluent speech. Nobody does. To perfectly fluent speech. But again, that starts to sound a little robotic. It's all there are disfluencies. Some of the common disfluencies are breaks, where you have a pause. Fillers like or so, repetitions of phrases when you're thinking about something and you just say the same word over and over. Stuttering typically do because there's an unusually high amount of those typical disfluencies. That's the primary characteristic, is that there's more but the secondary characteristics, which is another way to tell, or having like really tense muscles when the word won't come out like that. Sometimes they'll change the word that they're trying to say if that word is just not, go to another word. So again, to identify stuttering is one, there's more disfluency that exhibit these secondary characteristics while we're planning the next. But if someone is stuttering, they will likely exhibit these secondary characteristics at a large range. So you can have it mild, where most of the words are normal, 5 words, somewhere around there, being stuttered or repeated or surrounding those 5 words, along with the secondary characteristics. So it's a large range, but you're definitely going to see the secondary characteristics for all. This is just a far higher percentage of disfluencies. And when, let's see, I want to go back to cluttering together. Remember, it's not fast speech, it's actually that different speech sounds are going to you can't tell them apart. It's kind of like the motor program has decided to say an E and an and a as a like that. So that's most cases of stuttering are developmental, and most of those occur in like childhood here. Oh, that's important too. Primary characteristics, and then it moves into the secondary characteristics. The part of the disorder. There are some of the diagnostic criteria for the disorder, but what I mean is, it's a psychological thing or a secondary characteristics would go away. So you wouldn't have someone vocal folds and not be able to say a word if they weren't experiencing the stutter with it at the same time. All right. When you're under stress, stuttering happens more when you're under stress. I'm asking about, oh, nope, I'm lying to you. I did want to, kind of developmental stutters have a relative who stutters. There's a large genetic link between stuttering that you've learned about up to this point. There's a genetic factor, but there's also and other things that we don't know about. So genetic, but then there's also evidence that there could be other causes as well. Stutterers have slower reaction time. That's one. Broca's area, is that on a different? It must be. Where I have it, but that is definitely something that's on the exam. So here it is. Broca's area is subactive for people who stutter, which it is active activity. And that is, except for, yeah, this is the other thing. A good number, like every consonant, every vowel, you know, seeing where the stuttering can happen. Percentages of disfluencies to the percentages of words. Mostly just that, like the percentages while you're gathering the speech samples. And that pretty much it. Okay, any questions about how the exam is going to work? Oh, we do have a word of the day. Oh. Shoot. Okay, sorry. I'm so glad you said something about that. Sorry about that. And yeah, there's the day. The word of the day is lemon. What's important to know about cleft palate is, oh yeah, okay, I remember okay. Lip and cleft palate, or cleft palate, and or cleft palate, I should say. You can have maxillary involvement as well. Sorry, let me move my thing. I don't know. There we go. Maxillary involvement, pretty much all of them. It's going to cut through this portion right here on the teeth, be like this cleft palate. So you can have just cleft lip, you can have just cleft palate and cleft palate. And the other one that isn't on this is sub, and that's where back at the back of the throat in the velum, this is where you're going to see the cleft palate at the very top of the roof of the mouth. And it's this is the palatine process. Those aren't going to fuse together. All right. This is definitely cleft lip. We don't know bilateral cleft lip. So this would be unilateral cleft lip. This is bilateral cleft lip. Cleft palate, same thing during gestation as well. So we're not 100% sure. That can be impacted. So this tissue would still be there, but the actual muscles back of the throat wouldn't be present. And so that would allow you to consonants like p and b. And instead of producing nasals like m, so a lot of children who have this submucosal would say, might say like Teddy Mare, like that kind of. It's Teddy Mare, yeah, like that kind of. If you can feel your velum opening up, how difficult it is to produce bear, mare, yeah, like. All right. And does anyone remember what you can do to fizz lemon? Does anyone submucosal cleft palate? Does anybody remember what the thing is that people can wear to speak a little bit normally? I'm going to move the slides. You're thinking about what it could be. Go ahead and. Yeah, great, Sierra. So she said it's like a closed retainer for the top of your mouth. That's exactly right. I know I've got a picture of it in here somewhere. It's called a speech bulb, and it looks like, but at the back of the retainer, it's got this bulb, essentially allows for an easier, so if there's some muscular to move very far to close off the nasal passages, if there's provides for still a narrower opening, so the speech sounds, let me type that in here so you guys can see it. It's called a speech bulb. That's one thing. Of course, cleft palate can be repaired surgically. Well, not right after the baby needs repaired, but it's done pretty soon after birth. It's not important to know the weight, no. The problem with the submucosal cleft palate is mucosal cleft palate go undiagnosed, child born, say, in the United States. Yes, because they're not speaking yet. Yeah, there you go. Because you don't are great. So even if they're not speaking yet either, but we can see that in for some reason don't catch it in ultrasound. You'll notice it when the child is born. Real outward evidence. It's just a muscular dysfunction in with cleft palate. But it can also occur by itself until quite a ways into the development, into the language. They can do some vocal play. They'll, progress pretty much normal until we actually notice that they're not producing their high-pressure consonants. Velum well, but not perfect. But feeding problems are something that before they get their surgery, so cleft lip, cleft palate, submucosal cleft palate, that's because the mouth and the nasal passages aren't separated for regurgitation of milk or whatever they're drinking. And then also, another feeding difficulty is, like I was showing you, out of a bottle kind of follows the same principle. You have to be able to drink out of a bottle. So that is going to be a problem as well. Up here that never closes. I mean, I guess unless you pinch the nose, unnecessary. There's other things we can do. So actually suck on a bottle. So instead, do I not have a better picture I should show you? The one on the left is kind of dependent on kind of guessing when they want to be able to drink, and they're pushing the milk out. It has this one-way valve that allows milk to go into the nipple, stays kind of pressurized, and then when they bite down on it, flow into the mouth. So that allows the child to, so if they want to take a breath for a little bit and not be drinking right at that second, to do is kind of bite down and then the milk comes out. So that you can help feeding until surgery. That is all I'm asking about. The hypernasality will be in there, but that's going to be with the compensatory, with the high pressure, again, just so you know. So submucosal cleft palate, the speech is going to be hypernasal. All that means is there's going to be a lot more than typical speech. They'll have producing the high pressure consonants P and B. They can have problems with some other, how bad it is, but the ones that I'll focus on are the really, and the compensatory articulation that they'll have is made or a glottal sound. Require that closure is before you get to these glottal sounds, or you can just create a nasal sound instead of. Okay, so the end of, that's all that's on the exam. So how it's going to work, so let me jump up really quickly. It is going to, will the exam open at 3:05 on Wednesday? No, I think I'll open it probably at noon, but you can also take it a little bit earlier if you want. And it's going to be Thursday night. So Thursday at noon and Thursday at midnight, you can take the exam. But you do have, they can like look at your space and make sure you're not cheating. So that's not having a time limit, I guess. And then you have to as well. Let's see, is there any, what are some of the other questions? Go ahead and type more questions. Yes. Really similar to the last one. So there's going to be a lot of just multiple choice, and so like there was last time. But actually, the matching is easy. You don't have to create extra questions with extra answers. So yeah, it's just going to be multiple choice, and there might be some pictures of like cleft palate, formants, pictures about formants. So keep an eye. Yes, the word of the day is lemon. Okay, looks like I answered all the other ones. Yeah, absolutely. If you guys have questions while you're taking the exam, you can email any of us. You can email me or Amy. Or problem with having it open from Wednesday at noon, we might not be able to get back. Oh, you know what? You can't browser. Yeah, exactly, Ashley. Yeah, Lockdown browser does questions, so that's not great. Study super hard. Will all be available until the exam is done. 11. I'll be checking things on my phone, so anytime you guys send me an email to my account, it'll alert me. No, that's totally, absolutely, go. All right, so yeah, go ahead and studying, and then doing it. Yep. Oh yeah, great. Yeah, thank you. Yes, all day Thursday. Yes, it is due right at all day Thursday until. Oh, well, 11:50 is when it's due. Not, yeah. Like 40, 43, something like that. 42, something just like. Yeah, there's going to be 3 just like usual. Yeah, open answer, yeah. You too. All right. If there are questions, then I don't know if you guys saw, we just got an email like right before we started this. This is for the rest of the semester, our online too. reviews and maybe some of our classes. So, worked for you. Yeah, even the finals. Yep, definitely. Interesting. All class, but yeah, it will be interesting. Have guest lectures. Yeah. So I don't know what their video that I'm going to put up that you watch at some point throughout the week. I want to do Zoom at the regularly scheduled. I'll let you know ahead of time so you can plan accordingly. I guess if you don't hear from me, and I will try to let you know as soon as possible when I hear from our guest lecturer. So I'll also take a poll better. There will be every scheduled time. I mean, I don't know if we're going to be meeting but there's going to be something for it. If it's a YouTube video, it'll just be up and you, but again, I'll let you know if the synchronous class, I'll let you know way ahead of time. Cool. Hey.
Can I throw something in?
Yeah, hey.
I'm there. I forgot my microphone doesn't work on that other laptop. I just wanted everybody to know I'm going to open up any questions. There'll be a discussion on Canvas. You can answer each other's questions, and Abby and I will be hopping in there all day. And we're always available via email too. So.
Perfect. All right. Thank you, Amy. And all right. I guess that's it. So, luck. I'll see you. I'll see you next week for exam. And again, check out the discussion board for questions. Good luck. All right. Bye.